everybody, and welcome back to another edition of the Physiotutors podcast. Today we have with us Roger Kerry, a physiotherapist in the UK, a researcher and an educator. Roger has done a lot of work surrounding the topics of today, hemodynamics and CAD. So look, Roger, it's a very brief 2-second little intro about yourself. Why don't you take a couple minutes, tell us who you are, what you do, and then we can explore the lovely world of CAD and hemodynamics and why we as physios should be paying more attention to it.
Great, Sonny, thanks. Yeah, as you say, I'm Roger Kerry. I'm from the University of Nottingham in the middle of the UK. I'm a chartered physiotherapist, worked for a while as what was then called an extended scope practitioner, whatever they're called now, in orthopedics. And now I mainly sort of teach and do a bit of clinical stuff here and there and everywhere. And it's really thanks to a colleague of mine who many people will know, Alan Taylor, who we've been doing some work for a long time. He did his master's thesis on some vascular issues in elite cyclists back in 1990 something. And from there, we developed this interest into hemodynamics, which we're going to go on to explain all about, I guess, and its relationship to physiotherapy, really. I guess that's about it.
Can you give us a little bit of a background on exactly what hemodynamics are in this context? A sort of more tangible definition that people can use.
Yeah, absolutely. It's basically blood flow, arterial blood flow, or venous, the way our blood flows around the body, the way it's pumped around the body. And I get what you mean. It's a bit of a confusing term, because in medicine it means something specific. In physics it means something quite specific. In this context, we're not making something up. We haven't made up the concept of hemodynamics to sort of sell to physiotherapists or something. We are using what it's meant in medicine and physics, but trying to sort of simplify it, I guess, really. And it's basically the concept of, if our blood gets pumped out by our heart, it goes around our body, comes back, and if there's something wrong in that system, not so much the heart, but the peripheral vascular system, if there's something wrong with that, if the blood isn't flowing the way it should for whatever reason, that can be a potential source of pain. And the problem is, because body movement relies on a good blood supply, the pain side of that can present as movement related pain. So it looks quite neuromusculoskeletal. So that's the crux of what we're getting at. Some vascular flow problems can present as movement based problems, which can easily be misidentified as something neuromusculoskeletal, when in fact they're vascular in origin. So that's what we wanted to unpick right from the early days. Say, oh my God, in the cyclists, it was these guys have got exercise-induced leg pain. Let's explore why that is. Actually, a significant proportion of them, the reason is it's a blood flow issue, not a muscle issue, or not a tendon issue, or not a disc issue, or whatever.
Okay. So is that, if we're looking at those cyclists, is that something that we may be able to relate to claudication or something like that?
Essentially, that's what it is. It's claudication. And the sort of in the older age group, we're more familiar with thinking in those terms. So we think about 72-year-old woman with intermittent claudication because she's a smoker or a family history or whatever, and it's quite clear to see she gets pain after walking 100 yards in her calf, and it settles when she has a sit down. So we associate that claudicant pattern quite comfortably in certain age groups and certain background pathologies. But then when you look at, a 19-year-old professional cyclist in Belgium or Holland, and they're complaining of this performance impacting calf pain or thigh pain, blood flow issues tend to be low down on the list of the things we naturally inclined to think about because of the age and fitness level of the patient. So what we're trying to say is, although vascular pathologies on probably aren't as common in 19-year-old elite cyclists as they are in 72-year-old women. They do still present, and actually it's the level of exertion, level of sport, that is one factor why they do have that. So we're seeing these vascular pathologies and vascular problems at both ends of the spectrum: very, very unwell, unfit people, and very fit, well people. So we're trying to just map that out a bit better.
We'll make a brief sidestep into the other section or other part of today's topic. What about the cervical arterial dysfunction, the CAD? What's that specifically?
Well, the background story for this is quite interesting. Well, for me anyway, because so there's like the old traditional manual therapy side of that, the VBI, the vertebrobasilar insufficiency, and the manipulation issue and all that. If we just forget about that for a minute and think the story that myself and Alan went on was, we started to look at these vascular flow problems in athletes, in exercise-induced leg pain, and in arm pain in overhead sports, and then the middle ground as well. They're not elite athlete and they're not pathological person who is prone to different types of some of these vascular pathologies as well. And then, so we looked at the lower limb, the abdomen, the upper limb, the hands, and the head and neck was just really an extension of that. So you start seeing these patients and reading the literature behind it and thinking, actually, the same sort of flow issues that affect the elite cyclist in his lower limb, or the fireman in his shoulder, conceptually the same mechanisms exist in the craniocervical vascular structures, and that's no big thing. It's nothing weird, it's nothing special, it's nothing we should freak about. It's just the same. So we can think about it, we can clinically reason it, why somebody might have headache because of vascular flow. It just makes sense because of what we know in the leg or whatever. So it's no real surprise or nothing special or anything. But then when you bring in the whole manual therapy story again, it all sort of, I don't know, people freak out about this thing called VBI and manipulation or whatever, but it's all been taken out of context and misinterpreted in what it is really. And we can make that so much simpler and so much easier to understand, and therefore provide much more confidence for clinicians when they're dealing with people with headache, in the same way they think of somebody with exercise-induced calf pain. It's just the same sort of level of differential diagnosis thinking. So we spent forever trying to reconceptualize the whole head and vascular thing in the head and neck, and called it cervical arterial dysfunction, meaning the cervical arteries, there isn't an artery called the cervical artery. It's just, any vessel in the head and neck we class as the cervical arteries, arterial vessels. And dysfunction, meaning a range of pathologies, including things like dissection or atherosclerotic disease or compression of the vessel or whatever. So it's a really broad umbrella term, but just trying to reconceptualize head and neck pain as a result of vascular issues, really.
In a way, it's sort of bringing an umbrella term to also highlight and bring a little bit more recognition into the fact that these pathologies are there and should be treated as such.
Yeah.
Okay, so where do these two things then cross over?
The hemodynamics of anywhere below the neck and the hemodynamics anywhere above the neck, they're the same. It's the same. I suppose the only thing that makes it different is the range of signs and symptoms, because if you think about an arterial flow limitation to the lower leg, pain is a manifestation of that. And you might think about ischemic pain in the calf or in the foot. And you might get some neurology as well, some tingling or something. And it's fairly simple. It's just pain and maybe a bit of paresthesia. I suppose the only difference with the stuff above the neck is the range of signs and symptoms are a bit more complex, in inverted commas, because you're dealing with the brain. The brain is the target organ. So you reduce blood supply to the brain, and all sorts of weird things can happen. Maybe that's the reason that puts people off. But the crossover is fairly simple. The crossover is, there is no crossover really. It's just the same. It's just the same thing. The only difference is the target organ is different. It's not the toe anymore. It's the brain, and therefore the manifestation of a limitation of blood to that target organ is different to what it is to the toe or something.
Obviously, you've got my questions there. And one of my questions was, is it something that only a manual therapist should concern themselves about? Now, it's quite clearly been answered in that it's not just something that's going to affect from here up, from the neck up. It's also going through the whole body. So what sort of things should we be looking out for then, whether you're in general orthopedics, if you're extremity based or whatever? You've mentioned paresthesia, pain. What other indicators are there that we can look for, that we can say, okay, this is more to do with hemodynamics rather than a general MSK complaint for a patient?
Yeah, so we're sort of shifting it round, really. I mean, it's a great question that you said, because you said something like, is it something that only manual therapists need to consider when doing their assessment, and whether or not to use a manual therapy or manipulate or something like that.
Yeah.
So that's sort of too little too late if we think like that. So the question shouldn't be, is this person safe enough for me to treat with manual therapy? And obviously the head and neck is the most obvious example. Is it safe to manipulate? It's completely the other way around. It's the early stage history taking differential diagnosis, whether you're working in orthopedics, whatever area of physiotherapy you're working in, and it's the same. The idea is, some people present to us with painful conditions or seemingly neurological conditions, and a proportion of those could be vascular in nature. So the differential diagnosis comes up early in the history taking, where you're looking for the key features that would differentiate it as a vascular phenomena. And like you said something right at the start, one of those key features, particularly if it's lower limb, is effort-induced pain, so an intermittent claudicant pattern. And again, at the risk of repetition, that's easy to identify in certain groups of people, the older, very pathological. But if you're looking at somebody's buttock pain and they say something like, well, it hurts when I go upstairs, as therapists, as physiotherapists or manual therapists or whatever, we're sort of taught and inclined to think, oh, right, buttock pain going upstairs, that's something quite mechanical, like a sacroiliac thing or a lumbar thing or something like that. But if you plug a bit of hemodynamic theory into your brain as well, then another differential diagnosis is, actually, it's not just the mechanics of going upstairs, it's the effort of going upstairs as well. So is blood being restricted to the muscles that you need to use to get upstairs? So, and then you can start to ask questions about things like, okay, what sort of pain is it? Where is it? How long does it take to settle? Looking for subtle clues of an intermittent claudicant pattern, and also the description of the pain as well. And then you need to think, well, vascular problems in the scheme of things are relatively rare. So what is it about this patient that would cause them to have a vascular problem? So then you look at risk factors for vascular problems and try and weigh that up. So you're just plugging some theory about blood vessels into your clinical reasoning brain and trying to add that as a differential diagnosis.
For most of us then, it's easier, not easy, but easier to see the pattern of, if you get someone who comes in that's overweight, they've got a high stress job, these sorts of factors that you're like, okay, they might have a vascular problem, they may have cholesterol issues, what have you. But you also mentioned at the beginning that this can also be with elite level athletes, or generally fit and healthy individuals. Now, hands up, I'd say it wouldn't cross my mind to think of vascularization if someone presented with pain and paresthesia that was otherwise fit and healthy. I'd go into neuro testing of some sort. I wouldn't then think, okay, the vascularization aspect wouldn't cross my mind unless I was a little way down in treatment and nothing was happening, and I'd say, right, go back to your doctor. What are the signs and symptoms that we should then pick up with for someone who otherwise seems to be relatively healthy?
So this is the challenging bit, and like you say, often, I mean, the cases we've seen are often the ones that have failed failed treatment, like you say, and again, that you could argue there's not much wrong in that. We have a certain package of education, a certain package of skills and knowledge, and doesn't quite fit some people. So the empirical evidence for that is that they fail to respond to treatment, so we refer them on for something else. But it's leaving it down to luck and chance a bit, that is, as well. We want to be better than that, really. We want to think, hold on, before we try 6 weeks, 6 months, 6 years of treatment or whatever, let's try and identify what's going on. Now, so I will get to your point about what do we look for clinically in it, but in order to really sort of answer that, again, it's important that we know something about the theory of the pathologies of hemodynamics. And we've mentioned things already like dissection events and atherosclerosis. But in the young, fit athletes, the background pathology is slightly different. And you need to understand that to understand why they have got that problem. So you don't tend to see so much atherosclerotic changes, for example, in young athletes. But the mechanism of pathology for the blood vessels is directly related to the sport they do and the amount of the sport they do. So quite simply, the simplest example, again, I'll use cycling as an example. Imagine you've got some blood vessels going down your leg and you're pumping blood at them at high velocity speed through them for long periods of times in biomechanically compromised positions. So, you're crouched over on the bike, your leg muscles are demanding a lot of blood, cardiac output is at peak, and you're pumping away and it's going up and down the system for hours on end, days on end. Now, it's that actual velocity of blood going through the vessels that can be, in some people, the cause of a pathology. And the pathology is it's called endofibrosis. So it's literally a scarring tissue of the endothelium of the vessel, which is caused by the sport. It's caused by the high load sport. So the signs and symptoms of that are, again, exercise-induced pain. Now, the problem is it's the ischemic. So you might call that ischemic pain, i.e. the muscles becoming painful because they've got less blood than they need. But to confuse the picture, what you also see in these people is a period during the timeline of pathology when there isn't ischemic pain there, because actually ischemic pain is fairly easy to identify. You just say, how much effort does it need to come on, and how quick does it go when you stop that effort? And there you've got your claudicant pattern. But that's fairly late on in a pathology. And really, we want to try and identify people before they get to that stage. They can have pain in other areas, which isn't ischemic, but it's still vascular. So the blood vessels themselves can be a nociceptive source of pain. So if a vessel is scarred, or it's inflamed, or the massive psoas muscle is compressing it, the vessel itself can be a cause of somatic pain. And for example, in cyclists, it's common that they get this band of pain around their thigh, which is very musculoskeletal in nature, but it's not, the source is not musculoskeletal, it's vascular. So we're starting, over the years, we've been able to map out almost these vascular tones of pain that aren't ischemic. So then you put the picture together and you think, okay, you're a guy who's rapidly increased his exercise output. You started to get this band of pain around your thigh. Now you're starting to get some mild calf or foot problems. It's all adding up to like this vascular picture. And then, of course, you can get onto physical examination as well, which may or may not support what you're thinking. So I'm not saying some of this is easy, because a lot of it isn't. There's a lot of head scratching and thinking. And you've always got to bear in mind the prevalence of the vascular things, which is low again. So the chances are it's not going to be a vascular thing, but in a seemingly increasing proportion of these people, it will be.
With regards to the prevalence then, you say the seemingly increasing proportion of people. Do you think that this definitely calls for conjecture, but do you think that could be also due to the fact that with regards to some sports, people are now picking it up when they're younger? And if we're picking up sports when we're younger, and let's say if I want to get my kid when I do have them, I haven't got any kicking about, mum and dad, don't worry. I start them cycling, and I start them cycling from a young age, and then I get them doing it 3, 4, 5 times a week, and then they go further, and then they go harder and longer on those cycling trips and whatnot. And do you think that that has an element in that? This is why we have then 19, 20-year-olds who then develop this endofibritic problem. Again, it calls for conjecture, but yeah, do you think that that could be a reason why we're starting to see it?
Yes, but no. So I think we've got to be careful about how this thinking impacts on like the physical activity agenda and exercise. And I don't think at all we should worry about something like, just reframing what you're saying there. I don't think the concern should ever be, oh, there's a small chance that somebody could get some vascular flow if they do exercise, so therefore I won't encourage my kids to do exercise. That's not it at all. But I think the increase in prevalence that I sort of alluded to probably comes from better diagnosis and recognition of cases that have until now not been recognised. And without being too speculative or critical, but there is some stuff in the literature about particular sports like the long distance running, middle distance running, cycling particularly, that the use of performance enhancing drugs has got a potentially significant impact on the rate of this. And if you look back at the 80s and 90s and early noughties and looked at the patches of particularly in Europe, where these things were being most identified, vascular problems in elite athletes. Again, being a bit cautious with the way I'm saying this, you can sort of relate it to certain training methods that certain
say no more athletes
were using. So there is definitely something about the constituents of our blood, and how they're affected by the things we put in our mouths, and what happens pathologically in the peripheral vascular system. But I don't think there's any worry at all about getting people to do stuff, get them on the bike and running and things like that. It's just that if an athlete gets pain, which they invariably will, what's the source of that pain? And we know that I say low prevalence, but and it's really, really difficult to put a figure on that because it's so varied between body parts and activities and everything else. But if we said something like between 3 and 10% of exercise-induced pain being of a vascular thing, I'd be fairly confident saying that that's about the rate of vascular problems you would see in these sorts of things.
Okay. And then how would we go about assessing a patient's cardiovascular health then for that? Yeah, this isn't something doing a VO2 max test or something like that is going to identify. So what would we do then to assess that?
Well, again, it depends on the person and the suspected pathology and the age and activity of the person. So the assessment of their cardiovascular health in relation to, I'm guessing from a clinical reason point of view, you're thinking what's the risk factors from this person that contributed to this hypothesis I've got. It would be different throughout that range of people. So in the elderly, intermittent claudicant femoral popliteal atherosclerosis, you're looking at traditional cardiovascular risk factors. Is there family history of cardiovascular disease? Have they got high blood pressure? High blood pressure is the big one that sort of cuts throughout mostly, particularly the CAD stuff as well. And the things, do they smoke? Have they got a bad diet? Blah blah blah. Those traditional cardiovascular risk factors, but obviously that's different. They're not going to be apparent in the young athlete, and we don't fully understand what the risk factors are, what the cardiovascular risk factors are in that younger group. There's lots of suspected theories like excessive vessel length in a cyclist. If you imagine your external iliac artery going down the front of your hip, And if that was excessively long and you was in hip flexion all day, it's more convoluted, so there's more turbulence and more velocity. And the French have always had this theory that that's one of the main things, but you can't image everybody just on the chance that they've got an excessively long external iliac artery. That would just be ridiculous. So again, you're left with just looking at what there is for the signs and symptoms of those things. But as we progress through age up the pathologies, then testing for and asking about cardiovascular risk factors becomes more important. And it's to say, if you then flip straight to the head and neck thing, and look at head and neck pain as a result of vascular pathology, and you take something like Lucy Thomas's data from Australia, where she looked at prospective data looking at people with head and neck pain and stroke and blah, blah, blah. It's sort of categorized into two chunks of people. Those younger, say under about 45-ish, and those over 45-ish. And the younger ones tend to not have cardiovascular risk factors as strong predictors of what's going to happen. They have things like trauma, so trauma to the vessels, which is essentially the same as what's happening in the cyclist. They're just traumatizing the vessels. And then the older ones, the cardiovascular risk factors are more important in the differential diagnosis. So a lot of that is to do with age and activity levels.
Okay. Talk about throwing a spanner in the works on, thinking that cardiovascular risk factors would be a nice indicator. But there's more to it. As with anything, there's more when you peel it back. Yeah.
Yeah.
Okay.
It would be nice if it was. I mean, some of those younger people do have family histories of cardiovascular disease or weird underlying things, fibromuscular dysplasia or factor V Leiden and things like this. But they're really rare, and they're not strong enough to say, oh, because you got that, you got something wrong with your blood vessels, so go and get investigated. It's a bit more nuanced than that.
Okay. And then what are then the signs and symptoms we should look for the head and neck in that case? Because, someone might present with a headache, but then there's multiple different types of headaches. So someone is probably going to go down that pathway first before cardiovascular comes into their frame of mind.
Yeah, and so they should, because on chance it will be more likely to be something non-vascular. But we always want to be aware. Again, it's that first few minutes of the history taking, that first bit of information. We've got knowledge about what type, what areas of the head are affected most commonly by the vascular tissue. So, for example, the vertebral artery will typically refer pain to the occipital area of the head. The internal carotid artery will typically refer pain to the temporal parietal area of the head. So we've got things like that, but that doesn't rule something in or rule something out by itself. The nature of the pain is really important. And we do know throughout the decades of case studies, the one consistent feature that patients talk about is that their head pain and neck pain feels unusual and feels different to any headache they've had before, and things like that. So it's just like classic red flag screening, really, the first or worst. But in this case, it's not necessarily the worst, it's the difference. So first, worst, or differentest, whatever. You're listening to the patient saying, you know what, I've had headaches before, but this isn't quite like the other stuff. Or I've twisted my neck before in rugby, or I've had a fall or a tackle, but this is a bit different. And I know it's not much to go on, but that's really gold, listening to the nature of the pain. And then, of course, whether it's worsening over time or not, because this sort of pain will be mechanical in presentation, because it, again, related to the stress on the blood vessel. So, ouch, it hurts more there, it's easier there. But over time, it would typically be getting worse and worse if it was truly a vascular thing. And then they would start to get other ischemic symptoms. So we talk about this pre-ischemic stage, which is essentially just pain, and then the ischemic stage, where you can get a whole host of neurology related to ischemic changes in the brain. But then again, it's a bit too little too late by the time you get to that point, because they're probably going to stroke out big time or something. So our job is to try and identify them sooner rather than later.
Okay, that was going to be my next question there. Sort of, how does it then develop, and then what are the risks of this going undiagnosed?
So the development is generally, whatever you're talking about, the foot, the calf, the thigh, the buttock, the back, the head, wherever, the arm. The development is generally from the pre-ischemic somatic pain stage to the ischemic vascular neurological changes, and then depending on what body part you're thinking about will dictate the risks. So again, ranging from your typical 70-year-old intermittent claudican, obviously the risk there is something like amputation or something. In the cyclist, the risk isn't, we've had very few cases of amputation in young active athletes, but what we do know is really interesting is that later on in life they can be candidates for amputation in the sort of 5th and 6th decades of life if they've had these experiences in their youth. So that's like worst case for peripheral stuff. The next to worst case is just disabling ongoing pain and them limiting their function or their performance or whatever, so they back away from the sport. And that's always an option for treatment. You can say, look, you can either have this surgery, or you can have this, or you can just stop doing what you're doing. And if somebody's mid to late 20s and they've been elite cycling for 10 years, they might be ready to knock it on the head anyway, and they might find that performing at a non-elite level is just knocking that bit of performance off where they don't get the vascular problem anymore. But then you still need to know what's underlying there and whether it's going to bubble away and manifest in later life. And obviously the worst case scenario risk for the head and neck stuff, worst case is death, second worst is stroke, third worst is ongoing disabling undiagnosed head and neck pain. And it's only death because it's the brain. You know, you're not going to die of having blood reduced to your toe unless you've got a massive infection.
Something a bit different by that point.
Yeah. But it's only by virtue of the fact that the brain is the target organ for the cervical vessels that death is a worst case outcome, because life pretty much depends on you having a functioning brain. But you know, these are rare events. They're not, I mean, stroke isn't a rare event. Death from undiagnosed CAD is fairly rare, but does happen.
You've sort of mentioned one thing there in terms of what we can recommend or what we can do for someone if it's someone performing at an elite level. Maybe if they bring that down a little bit, it then doesn't push the body to the point where they're developing their ongoing issues. What can we do as therapists once we've moved past that assessment point? We're getting towards treatment. What is it that we can do for someone, whether it's in the periphery or if it's from the neck up?
Well, most of these are going to be shunted off to vascular medicine or neurology, and have into medical or surgical interventions related to whatever pathology they've got. So in terms of management, in terms of physiotherapy management, there are some, you know, if the cause of the vascular problem is something like performance and exertion levels, we've got a say in that. We can work with patients to work out what is happening, and that also relates to biomechanics as well. So it might be that biomechanically somebody on the bike or, you know, bowling their cricket ball is doing it in such a way where there's compression of the vessel. And there are ways to test for this. You know, we use blood pressure monitors a lot, and just looking at things like if you've got a blood pressure monitor at your wrist and you take the blood pressure and then you put your hand up here you know, if the blood pressure plummets or the pulse obliterates, then there is some compression, because we've got normative values for all these positions. We know it drops a bit, but if somebody drops systolic, say from 120 here to 10 there, we know there's a massive biomechanical obstruction. So we could work with people, if as long as there's not a limb or life-threatening underpinning pathology, which we might need an opinion on, then we can work with people sort of biomechanically and performance-wise to sort of manage those symptoms. But we can't just go in and do that. We do, if you suspect, and all the cards are stacking up to saying this is most likely a vascular thing, you do need a medical opinion on that, and they do need some imaging to explore what's going on. And then we can do it. Posture is another one. You know, we've had like lorry truck drivers with ischemic hand pain, and you say, well, sit up a bit, and oh, they're fine. But you can quantify that with looking at their wrist blood pressure in those positions, and it's that sort of stuff is easy.
Yeah. Okay. So I think maybe I jumped the gun there and jumping straight to the treatment side. You've mentioned there the use of the blood pressure cuffs in assessment, positional dependent assessment. So with the arm raised above the head, or however the truck driver would normally sit. What other assessment strategies can we use if we've highlighted someone that we think may be appropriate for this kind of further investigation?
So there's some really simple things like pulse palpation, but we, again, in the elderly advanced pathology person, they may have very diminished pulses at rest. In the athlete, that's not likely to be the case, so we need to look at their pulses after exertion to see what happens to them. So you would expect the pulse to be bounding away after somebody just done 15 minutes at a high heart rate percentage on the turbo trainer. But if their pulse is you're unable to find it, then that's a fairly clear sign that there's an arterial flow problem. We can look at capillary refill times in the nail beds of the hands and the feet, and look for normal return of colour from that. And just going back to the blood pressure monitor, there are formalised and well-tested diagnostic tests that rely on blood pressure measurement, like the ankle brachial pressure index, the ABPI, that you can use for lower limb arterial insufficiency. And there's a bunch of normative data behind that. We know what's a positive cutoff point. We know that on a positive test and that it correlates really well with gold standard MRA findings. So for something like the lower limb, we have got a sort of battery of fairly easy to do functional tests looking at blood flow measures. But just using your hands, 9 times out of 10, just using your hands and either feeling for pulse obliteration after exercise or in a compromising position, or if you suspect something like aneurysm formation, so classically the abdomen, you know, back pain as a result of abdominal aortic aneurysm, should be in our back pain differential diagnosis as a very severe red flag. And palpation of the abdominal aorta for an aneurysm formation is got a high diagnostic utility from even quite inexperienced clinicians. You can get skilled very quickly, very easily to detect abdominal aneurysm, and the same for carotid aneurysm or subclavian aneurysm. So you feel this bounding pulse. So it's not high tech, high sophisticated stuff. It's all very functional and very, very easy to explain stuff. And then, like I say, with things like the leg, we've got some really good gold standard clinical tests to use.
Okay, and then what about with the cervical region?
Yeah, so it gets a bit more complicated. We're thinking it's really hard to measure the blood pressure of the brain.
Special kit.
A special piece of kit there. But we can look at palpation of the carotid arteries, as I said, if you're suspecting aneurysm, which is just an indicator of atherosclerotic disease. But then we have to rely on signs and symptoms and think, right, what would happen to the brain if you stop blood going to it? And then you think, well, at the back, we're stopping blood going to the brain stem and the cerebellum. Very quickly, the cerebellum could get implicated. So we looked at lots of proprioception, gait, balance things. So there are clinical tests. We know that the cranial nerves, they sort of respond to ischemia. This is a really sort of crude way of talking about this. They will respond to ischemic changes quicker than the brain tissue, if you like. So you're likely to get cranial nerve changes before you get brain ischemia. So that's a really good indicator of impending brain ischemia. So looking, checking cranial nerve dysfunction, particularly the lower end ones with the transcranial extensions. So anything from cranial nerve 7 to the end, very likely to well, I say very likely, based on the data available, around between 60 and 80% of all people with carotid dysfunction, for example, would have cranial nerve dysfunction. And we I'm trying to avoid getting into any discussions about the VBI test and the functional positional test, but we know that things like that for the head and neck aren't really good sort of indicators of what's going on. So we perhaps back away from those and focus on cranial nerve examination, pulse palpation, gait and proprioception testing.
Okay. Yeah, there was something recently that came out about the usefulness of those positional testing and VBI testing and how it may not be so relevant as we once thought, but it's not my field. So I won't ask you to dive into that any deeper. Right. So then coming back to treatment side of things, let's say we've got someone, they've received medical intervention, whether that's pharmaceutical based or what have you. What sort of things can we expect on that side of it? And then how can we assist it, or what are the recommendations that we as physiotherapists should make to the patient to seek out for this when they do go back to the doctor?
What post-medical intervention though? So they've had the sort of vascular diagnosis, it's been treated medically or surgically, and then they come back to us. Well, again, back to what we do best, which is good education and advice on activity levels and function and movement, and not being, regaining some confidence, really, because often with these people, they then associate exercise with really severe disease that could have threatened their leg being chopped off or something. So, our role is then to provide the correct advice and education and reassurance and bringing them back to confidence to achieve whatever activity levels they want to do. There aren't any, written guidelines or strong recommendations because, again, of the rarity of these things. So we can appeal to our, normal parameters of practice and common sense, and there's no explicit evidence that any sort of passive interventions will necessarily play part of any rehabilitation. But advice, physical activity advice, education, re-establishing their confidence, and also their future recognition of onsets of pain in a reassuring way as well, and saying, it could be quite normal. We haven't spoken about the venous side of things, but something like DVT, deep vein thrombosis, or even after that's gone, there's still years, possibly decades of post-thrombotic syndrome, which can be quite painful. So then it just turns into a persistent pain issue. So we just go in with our pain education and pain advice sort of thing. So, but these are, don't get us wrong here. We're not trying to to build up an area of physiotherapy that's all a bit mystic and spiritual and saying, you know, we can work on the energy of your blood flow and things like that. That's not at all. This is a hardcore medical bio phenomena. You've got some pipes in your body. Blood's meant to flow in them. Sometimes it doesn't. Let's sort it out and get you back on track in a biological way. That's not dismissing the psychosocial side at all, because there is all that there. But that's what I'm saying. The hemodynamics is a structural biomechanical biological phenomena which we need to identify and then reframe in the stuff we do best.
Okay, so aligning my chakras isn't going to solve it then. No.
We could just set up a small trial and see what happens.
Going back to the diagnosis side of things, is it something that if we have access to it, we potentially could check in clinic with a Doppler or something?
Yeah, handheld Doppler, the small ones with a small probe that just give us a sound, or if you've got a duplex Doppler, and if you've been trained in musculoskeletal ultrasound imaging, the vascular imaging is actually really easy. It's just easy to see blood flow, but what is not so easy is determining what is pathological or not. But with either a duplex or an ultrasound Doppler where you just hear the sound, they do have some use clinically, albeit limited. So the main role for them is if you're trying to assess a peripheral pulse and you're not sure if you can palpate it or not, then it's often useful to have a Doppler to see. And then sometimes you can hear it on the Doppler and you think, oh, it's okay, it's just my palpation skills aren't great, but I can actually hear it with the Doppler. Same with a stethoscope as well. You can always use auscultation techniques, but they're not as reliable, and the diagnostic utility isn't as great. But using a Doppler for things like finding a pulse when you're not sure if it's there or not is useful. But we don't want to get over carried away and think suddenly we are vascular specialists and we can diagnose this, that, and the other. The gold standard imaging is MRA, magnetic resonance arteriography, and that is preferable to plain film, MRI or CT. So we want to direct as much as we can somebody towards an MRA investigation.
Okay, and then very briefly, what would be the medical or surgical intervention, just so that we know what to expect of someone walking back into the clinic post?
So again, very dependent on the pathology and the demographic of the patient. So in the young, active, elite cyclists, bypass surgery of for example, the external iliac artery is the most commonly used intervention. Simple surgery, just a small insertion around the hip, bit of saphenous vein or synthetic bypass of the vessel. That's the same in the FemPop bypasses in the 70-year-olds and things like that. And then in between that, there may be some sort of just drug-based thrombolytic therapy if it's venous or something to try and break down whatever's going on. Endarterectomy interventions, for example, in the carotid artery, just a cleaning out of the vessel. So not bypass, but just cleaning out. Stenting is an option for some people, depending on where the pathology is. It's not a good option for something like the cyclist, because if you imagine a sort of synthetic stent put into the vessel in the hip, which is a fairly rigid structure, the guy's just going to go back on the bike and flex his hip and destroy the stent. But a stent might be an option for somebody less active if the problem is in the sort of forearm or something like that. So again, as I say, surgical interventions depend on the type of pathology and the type of person. Medical interventions, for something like the CAD stuff, if you're thinking there's some sort of dissection problem or even atherosclerotic problem in the vertebral artery or the carotid artery, most likely that's going to be intracranial. So the risks of surgery far outweigh potential benefits. But often, particularly with the dissection patients, they just need some bringing down of their blood pressure, monitoring of their INR level. So the protocol is 3 days in inpatient on, just rest alone and monitoring can often normalize their cardiovascular status to give the body chance to repair or whatever, plus or minus whatever medicine is needed. So antithrombotic therapy if it's venous, or antihypertensives to help with the blood pressure. And then once their INRs are stabilized, they're good to go really with a package of precautions. And sometimes it's just nothing. If you've got nasty subclavian sort of aneurysm, thrombotic, and again, although it's extracranial, it's quite complex surgery. So it might be just let's see what happens, but try not to do 25 press-ups a day for 25 days or something.
Yeah. Okay. And then, look, as an adjunct, is it worthwhile if we recommend these people coming into a sort of MDT approach here? You've already sent them back to the doctor. They've had the surgical, medical interventions, what have you. Is it worthwhile that we recommend these people seeing a dietitian? Because that element might be relevant depending on, obviously there's a lot of nuance that goes into it, but depending on what their circumstances were that led to the arterial dysfunctions or venous dysfunctions, is that something worthwhile for some people?
I suppose for some people, if you've identified as a healthcare practitioner that diet is a significant part of what's going on here, again in the atherosclerotic changes in the middle-aged and above people, that may well be the case, and therefore good advice on diet can and will help as a measure to prevent further episodes of this sort of thing. But we do know, something like the cyclist diet wouldn't be such a factor for the endofibrotic changes, so you might not worry so much about it there. So yeah, no, and absolutely, and particularly the carotid atherosclerotic carotid pathologies, high cholesterol levels, fatty lipids do play a part in that. So yeah, MDT is always good, and in your example, that the dietary advice would be relevant for some people.
Okay. And why do you feel that there's not more attention around the hemodynamics if it can have, in the worst case, such catastrophic end results?
I have no idea. Alan and myself have been scratching our heads about this for 2 or 3 decades now, and I just don't know. I don't know. And it's really odd. You look back in some of those old, even some of the old Greg Greaves manual therapy books from the 70s and stuff. He was talking about some of this in terms of differential diagnosis. The osteopaths have a traditional historical. They started out, their old history was based around this thing called the rule of the artery. That you should always first attend to vascular issues, and then whatever's left is something that can be treated by us. Right back to Hippocrates, all this stuff's been is part of medicine and movement-induced pain things. And I guess it's just traditionally our education curriculum hasn't had room for it or something. But as I say, since the 90s, we've been sort of focusing on this, and we've seen very little change over those years in terms of the physiotherapy knowledge base. There's pockets of people who have an interest in things, but it's never sort of got into the curriculum as part of what we do. In the same way, all we need to do is think of this just as a part of the red flag package of serious pathologies. And we do talk about cancer, we do talk about infections, we do talk about traumas and everything else. But but for some reason, even in the latest sort of safety netting work for low back pain, which is an amazing piece of work, but it misses out. It doesn't refer to the vascular thing, which in terms of prevalence is probably a bit higher than some of the other stuff that's looked at. So I don't know. That's for you to solve something.
Well, there's the next question. Where are the gaps in the literature? Maybe I can get myself involved.
Yeah, well, absolutely. We just need case studies are always a good thing, but historically, a lot of our evidence base for this is from case studies and case series. As there are randomized controlled trials for interventions like stenting versus bypass for endofibrosis of the external artery and things like that. But in terms, a lot of good qualitative work would come into here. Look at people's clinical reasoning and develop their thoughts about pain, and but then just more basic levels of facts being inserted into the curriculum. No, it's good that we've had, Alan and myself have had chapters in things like Greaves' modern musculoskeletal therapy or modern manual therapy prior to that. So, you look at then a text on manual therapy, and at least there is some representation of hemodynamics in there. But I'm not sure that people, again, because it's not what we taught, I just imagine lots of people go, oh, there's the neurodynamics bit, there's the how to do grade 3 pluses on L4, hemodynamics, yeah, whatever. And then is this other bit. So, culturally, it's a difficult thing to crack.
Yeah, no, it's not even that it's not the cool or the hip thing. It's just the thing that's, as you say, not addressed. I cannot recall that being a topic in my bachelor's of something that we went over in. Yeah. So I think that there's something to be said there about you saying it's not covered really. In great detail.
Yeah.
No. Have you got any particular reading recommendations then for people?
Well, I mean, there's endless stuff about this in the medical literature, but it's a lot of it is impenetrable because it's quite theory based and it's seemingly irrelevant. And what we've tried to do is bring out the relevance and package that up in things like our chapters in Greaves. And we've had there's some good work. There's more and more case studies in the physiotherapy literature on things like dynamic popliteal entrapment in young athletes and stuff like that, with the popliteal artery behind the back of their knee gets entrapped by the gastroc muscles. So there's stuff in journals like Physical Therapy and the Journal of Orthopedic Sports Physical Therapy. In the last 5 years or so, they've got, again, mainly case reports for vascular problems that physiotherapists have come across. There is more attention to aortic aneurysms in the physiotherapy literature, again, in those same sorts of journals: Physical Therapy, Journal of Orthopedic Sports Physical Therapy, some in Musculoskeletal Science and Practice. What we don't have is a reference handbook or textbook for this sort of thing. Alan and myself had a 2-part series in a Sportex journal, but this is going back 10 years or so, and it's still relevant because nothing's changed. But that's our next sort of focus really. And we Alan and myself deliver education on this in a sort of 1 day or 2 day sort of package as much as we can, but we just need to bring other people in and establish a better point of reference for it already.
Okay. You say nothing's changed. What have been the developments then, or the movements in understanding, do you think, over the last 10, even 20, 30 years on this topic?
What, from physiotherapists or from the world generally?
Let's go for both. Yeah. That's, yeah.
I think the world of medicine and sports medicine have always had some interest in this. But and again, it's sort of geographical as well. The UK itself hasn't really been a party that's had that much focus on it. But if you look at continental Europe, it's been massive since the 80s. And that's largely due to individuals. Pierre, this vascular surgeons in the north of France, for example, Pierre Aram, and who've driven the way there, and throughout Belgium and Holland and stuff. It's always been something on the cards. In medicine and surgery, much so in America as well. But in physiotherapy, yeah, perhaps I'm being a bit harsh. I think there's probably been a general increase in awareness, and I think with things like in the UK, we've got the first contact practitioner agenda, more responsibility for physiotherapists in their differential diagnosis role and things like this. And this is just the sort of thing that fits in with that. So within that sort of pocket of the first contact practitioner or advanced clinical practitioner, there's probably more explicit awareness of these things. But again, it's back to that thing in the general populace of physiotherapists. I'm not sure really how much change is there. It's hard to quantify.
Okay. And you mentioned yourself and Alan do topics, teachings on this. I suppose, given the global landscape at the moment, maybe there's not anything in the immediate future, but do you guys have any plans for any upcoming lectures, seminars? How can people find you or get in touch if there was something of interest in future?
Well, yeah, we both work at the University of Nottingham, so we're always contactable there. We're both on social media, at Roger Kerry 1 and at Alan J Taylor, I think that is. And like you say, it's a bit difficult at the moment, so we're looking, as you know, with you guys, we've been looking at ways of looking for online provision for content, and so yeah, that's where we're heading towards. And then when we get back to face-to-face stuff, we'll get some sort of schedule of training lined up again.
Okay, grand. Is there anything else, any sort of last little bits or bobs you want to leave the people with listening?
No, just look out for we're about to publish the revised iFont cervical framework, which focuses on this whole issue for the cervical spine, the cervical arterial dysfunction, although there will be a slight terminology change in that. We've started to call it vascular neck pathology for the purpose of that document, but that should be available. We keep been saying this since 2017. It should be available in the next couple of months, but it really is at the end of stage now. So if you keep your eye on the iFont website, that will be out soon.
Okay. Feels a bit Game of Thronesy when you say we've been saying it for ages, but it's not turning up, like the dragons in the first couple of seasons. Yeah. Well, thank you very much for your time, Roger. Really appreciate it. And I look forward to reading that when it is out.
Great. I'm sure you'll have a wonderful time reading that.
Well, ladies and gents, thanks again for listening in, and we'll catch you next time. As always, wherever you're listening to this, we appreciate your time. And if you have any comments or suggestions, feel free to get in contact and let us know. Until next time.